my institute, ma'am, is not only the head of cornea and NTDS segment service, but also the founder and first director of Celestial Eye Bank, which was established back in 2003, a landmark contribution to the eye care in our region and beyond. Ma'am, we truly honored by your presence. With a great respect, I now invite Ashi ma'am to kindly deliver the welcome address in organization of today's program.
Thank you, and very warm welcome to all the speakers who are attending. I also wish there would have been more doctors, because this is also a field which is underexplored by physicians who are treating patients. Economic status where the facilities are catered according to that. But
from the Morgan's company. So it has been an interesting session till now. मजा आया सब लोगों को? थोड़ा थोड़ा है. Actually, we have talked a lot about the non-stress component. मैं थोड़ा सा आप लोगों को अभी एक step और ऊपर लेके जाऊँगा. My experience in handling the cases of squint from binocular vision point of view. We all understand, and in fact since morning we all have been talking about this. how important it is to for a human being to have a binocular vision. And in eye care, if we see, we have been seeing, in fact, we have been experiencing this, that somebody has a squint, and if somebody has lost his binocular vision, our only the way of treating is to have a surgery for the patient and make the eye straight. And very common practice which I have been hearing in my last 25 years is going on even now, that एक सर्जरी तो अभी हम कर लेते हैं 6-7 साल की उम्र में, तो उससे पहले तो कोई करना पसंद ही नहीं करता है. And then next may be required before the marriage, because if you are correcting somebody with a squint surgery, and then if you are not able to develop the binocular vision in an individual, there are more chances of recurrence of that state, because eye is not being used again, and then one eye is free to go again for the squint. So that is Isotropia. With the myopia, you go for a contact lens, isodivision will decrease because of your explanation you did so well. But if it is XT with the plus number, and if you're going for a contact lens, it may further increase it actually. So even if a surgery is planned, we prefer keeping the patient on the contact lens, re-measure with the contact lens, and then to decide for the surgery, the amount to be operated.
See, if you are, as you said, the hyperopia should be undercorrected, like if the visual acuity is same with the both, right? So ultimately we ask the patient to accommodate, like suppose I'm undercorrecting by plus 4 diopters. Ultimately we are just making early pre-presbyopia, like in the older age we make the patient
if you calculate where a Hofstadter's formula,
yeah.
so there is a good reserve at this age of 5 to have an accommodation. And how much you require for your routine work to do? Hardly 2.5 to 3 diopters. So that patient can do it. But as I was saying, the child grows. Once he will be reaching around 12 and 13, he will start demanding for that. And then he will start accepting more plus. That's how it happens. At this age, usually they don't complete.
You wanted to say, after the surgery, we need to increase a plus.
Not always necessary, but yes, as the child grows, it will be required. Because today he is able to manage by accommodating that well because of that strong mechanism he has within. But as he will be growing, the tendency of accommodation will be reducing, and he will not be able to compensate with that, and gradually need to increase the plus power.
Our first aim should be to improve the visual acuity, right? Yeah.
And in all these cases, the follow-up is very important. The frequent follow-ups, so that you can keep a check on how things change. In fact, we'll have to see whether this hyperopia or myopia is axial or refractive.
Image formation हुआ ना, brain ने देखा ना उसको. That means eye is being used. Brain is using the component of eye at that time. But अगर accommodate नहीं किया, इसका मतलब eye use नहीं हुई है. And that's how they end up with the amblyopia.
One more important thing I was just discussing, as you said, 9 diopter of hyperopia with 6 distance visual acuity is for let's say 636. You'll have to check the near visual acuity also. Sometimes with 6 at distance it is 636, with 7 or 8 it is 636, but at near there will be a difference. Maybe at near with +6 it might be N36 or N24, but with 8 it will be N18 or N12. So which means you are helping in improving the accommodation, as sir was saying, like XT with hyperopia, where the lack of accommodation is there because of the amblyopia and other factors. The exophoria will not be there.
Does not apply to pseudophakia.
I know it's not the pseudophakia.
Sorry, what accommodation?
All of the accommodation.
Sir, want to say?
So panel is open. If anyone is having any question, they can ask from the audience.
In these cases, never misunderstood, you have misunderstood one thing, that it is about under correction or over correction. It is all about optimal correction, which sir has already said. So it is not under correction, and it is you, it is me, it is all of us who has to think of optimal correction. It is not about under correction.
So I do take help of I think what Jayant is trying to say exactly is right. But there are certain cases where you need to undercorrect or overcorrect, right? So I'm coming with that. So suppose there is a case of IXT, intermittent exotropia hai, whatever the myopia is there or not there, and you feel child requires a surgery, but he is of 2 years only, and you want to wait till 4 years for the surgery. So that's the most suitable case where you will like to maintain the binocularity, and there you can take help of over minus glasses. Usually the cases which are having high AC over ratio means more XT for distance and less for near. The over minus glass works like a wonder. So till you are taking a call for the surgery, you can help a child in maintaining the binocularity, and whenever you are operating after age of 4, your surgical outcome is going to be good, right? On the other side, suppose there is a hyperopic patient with the EZO, then you will not like to undercorrect at all. You like to give the maximum plus with the whatever the strongest cycloplastic you are getting till the age of 8 years. But if the child is older than that, then again you follow the same technique. The maximum plus that patient can accept with the best visual acuity, because you not like to compromise with the visual acuity.
Even sometimes we have seen like at the age of suppose 7 years or 8 years, we have seen you are undercorrecting in case of accommodative esotropia, let's say 0.5, and with that visual acuity is 6.6, but a little bit like if we correct it with maximum plus, it is the visual acuity is 6.9. Still we will keep 6.9 only. We will not reduce the power because we have seen the esotropia will increase. So till the 8-year age, if it is the visual acuity is 6.9, but the squint is controlled, we will not reduce the power. If it is more than that, then we might need to think about it, and we need to start the vision therapy simultaneously.
Okay, done.
Alignment is more important than your visual acuity at that stage. So whatever helps you in aligning and maintaining that binocularity, do take the help of that. And because at the age of 3 years or 4 years or 5 years, what is this distance visual requirement? Right? So if something helps in aligning it, take help of it.
It's mainly based on the age, what kind of optimal visual acuity for their task requirement they need, and with that correction, what kind of an alignment you get. So you take all these things, and for each case you do it based on that.
Each case. Every day.
Each case is different.
After my 26 years, I still feel I every day learn from refraction only. That's my most interesting subject, refraction. People consider it very easy. I don't know how they consider it easy, but it's the most challenging aspect of eye care. Every day to learn something or the other. No, you will miss out a lot of findings.
So you can speak that again.
AR, I hate, I can say only that. In my 26 years, if you ask me if I've done any refraction based on the AR, 0. I've not done.
You also agree?
Yes, ma'am, definitely.
We also agree.
AR is like gives a very weird findings, especially in children. It is not gonna do help. Like there was a child referred to me
because they were getting a refraction of -9 diopter on AR. So they referred to me for expert opinion. I found plus 0.5 refractive error was there. So because of the fixation, actually they are not able to fixate and not having a stable fixation. So you will need the accommodation also.
Today's time we see isn't having the two patient and my entire management was different if we would have considered their aspect actually, their refraction.
Sometimes Dr. Suma has changed her treatment plan. Like she planned for surgery, and the moment we changed the refractive power and everything was normal, and then the patient was not required the surgery. So it happens sometimes with the change.
First case, the case which I took now, last esotropia intermittently who was having it. The surgery was planned actually for that patient. But it just came to vision therapy. Dr. Suma actually does that very frequently, just for an opinion. And I said, ma'am, no surgery required. And within, I think, 2 weeks, the patient was straight from that 45 ET. Because he was inducing that much of accommodative convergence, and that was resulting in the esotropia. And that was the pseudomyopia, what you were talking about. And that's how the refractive error increased point -1.25 cylinder to -6 spherical with -1.25 cylinder. So I just gave him a homide with the progressive lens, just to make him learn to relax the accommodation, and within 2 weeks the child is straight.
So are there any risk factors who are the patients who will develop accommodations? Like, are there any defined risk factors which is general?
Lot of whatever I have experienced in my life, they have something or the other related neurologically or psychologically, and they are the ones who result into that.
So we see a lot of these cases, especially before NEET exam.
Exactly, before NEET exam, board exam.
Board exams.
I mean, the one I was talking about, actually he has a pre-board now. So he was for that only, but then you have to help him. So, yeah, give bifocal, but give progressive lens with the homide, and now he's fine.
So I think everybody is undernourished also.
Yes.
Like even
Over-educated and
like even single, like there was a child while I was in shop, there was a child, her school got changed. Because of that, she developed spasm, accommodative spasm. She was much into this, like she had some issues and she was not doing well in the school, she was not familiar with the others, so she developed it. So we just asked whether you have something in your mind or something, like she told this is the
I think
reason.
we should all get together, pool and data, and we publish.
First photo, then
Spasm of near reflex cases we have reported quite few. Yeah, we published that. And after COVID, in fact, I saw a lot of kids coming with that kind of problem. Acute onset esotropias with diplopias. So,
And nowadays, one more thing I'm getting lack of accommodation, accommodative insufficiency. Many people are in depression and they are taking anti-depression medicine, and they are developing this accommodative insufficiency nowadays.
I don't ever slow up, no I don't take shit. I got no love for the fakeness. If you wanna play tough and wanna hate this, I'll always show up. I don't ever slow up, no I don't take shit. I got no love for the fakeness. If you wanna play tough and wanna hate this, I'll always show up and make a statement. I don't ever slow up, no I don't take shit. I got no love for the fakeness. If you wanna play tough and wanna hate this, I'll always show up and make a statement. Everything I do so instinctive and so passionate. Every word I move so descriptive like an adjective. I got a vendetta against people who patented being negative when you should be getting after it. I got facts over tracks, this and that. Spitting slow, spitting fast, I could roast, I could gas. Think I'm okay at last, but I don't know if that can erase all the past. And the pettiness, a reflection of the emptiness. Hilarious, you think you're worth my time, you're delirious. Mysterious, because you hide behind a fake exterior. Inferior, you know I'll always be a bit superior. Get off of me, this ain't no humble brag. I want you to hear words, you can say them back. I want you to feel free from the chains at last, and to believe in what you got, it was built to last, yeah. Now that I've been put through hell, I never got anyone's help. I had to do it all myself. I don't ever slow up, no I don't take shit. I got no love for the fakeness. If you wanna play tough and wanna hate this, I'll always show up and make a statement. I don't ever slow up, no I don't take shit. I got no love for the fakeness.
take away. I could play a million mind games, but instead I say something not illogical, something that is topical. Rub it on and watch it go, make yourself unstoppable. Dreams are irresponsible, but they're always possible. If you just believe, you could be so remarkable. Thoughts in my head, a collage and they spread. I'll be great one day, going off on my meds. No, I'm not giving up, no, I'm not giving in. I will make it to the top, taking off in the wind. I gotta make it, I'm saving every day to taste it. I'm patient, but my mind, it can hardly take it. I'm chasing a dream that I've had for several ages. A vacant, modern kingdom for the taking. Now that I've been put through hell, I never got anyone's help. I had to do it all myself. I don't ever slow up, no I don't take shit. I got no love for the fakeness. If you wanna play tough and wanna hate this, I'll always show up and make a statement. I don't ever slow up, no I don't take shit. I got no love for the fakeness. If you wanna play tough and wanna hate this, I'll always show up and make a statement.
I don't ever slow up, no I don't take shit. I got no love for the fakeness. If you wanna play tough and wanna hate this, I'll always show up.
We'll come here again after a short tea break. But whoever wants to get a surprise and a gift, small token from
I'm Mrs. Sonia Sharma, optometrist, role in binocular vision prevention and development. Is present 44% of all patients with amblyopia. Why? Can you explain that, please?
Because the visual acuity is poor in those patients, and there is a very nicely presented in you can see in pediatric optometry book also. They have mentioned very nicely that the visual acuity varies as per the fixation point. If the amblyopia, if the visual acuity, let's say 6/60 or less than that, which means the fixation will be at the peripheral area. Okay, and towards the fovea, the visual acuity improves. So, as per the visual acuity, the fixation will vary. So, they have seen in 64% patients, in case of amblyopia, there will be a eccentric fixation. So, we'll have to be very careful whether we need to go for a conventional patching or inverse occlusion patching in that case. So initially we go for conventional patching only, but once we feel okay fixation is not good and it is not improving, or we need to check eccentric fixation in all amblyopic patients ideally. So if it is there, then we need to plan accordingly.
64% patient in amblyopia. Why?
That's why, because the visual acuity is poor, so the patient is not fixating from the fovea, which means, so it tells you indirectly from which point of retina the patient is fixating actually. Fixating from the fovea or fixating from the mid part of the retina or the peripheral part of retina. Like if it is in counting finger, vision is in counting finger, which means the from the extreme peripheral area the patient is fixating. So that tells you indirectly, because the fovea is they are not using the fovea basically.
Thank you so much.
लाइक बोलते हैं, ठीक है। हमारे पास ये है लेंस लाइक ये कौन सा पावर है, माइनस है और इतना माइनस है तो हमेशा याद रखो रेड इज फॉर माइनस, जहाँ भी रेड में जो उसका कुछ माइनस है इसका रेड इज फॉर माइनस हर दिन, बट इसमें से कुछ नहीं होता रेड में इसका कभी माइनस का तो ये प्लस है
इसमें इसमें
name is the Brocust. Brocust means Bro मतलब डोरी, उसकी मतलब डोरी और ब्रो क्या है? ब्रो क्या है? ये जो पहले बार इन्वेंट किया था उन्होंने ब्रो, जब तुमने फर्स्ट टाइम जब तुमने ब्रो था और डोरी जो उन्होंने इन्वेंट किया है वो भी ब्रोकस्ट है। उसमें उसके चीज भी छोटी है इसमें। पहले क्वेश्चन कन्वर्जेंस इनपुट लाते हैं दो से मिलाते हैं आप convergence and convergence क्या है? Convergence ठीक है, मतलब only या without वो आप लगा सकते हैं ठीक है, तो आप बताते हैं अगर किसी केस में convergence deficiency है, first start the doing like this and after this they should try to make it single. If they are not able to make it single, just wait and then try. If the patient is saying single, then go ahead. Okay? Still, patient is saying double, wait again. If patient is saying single, then go ahead. Okay? So, like this, you will turn. Okay, so this is a convergence improvement. And then we can make the 2V. So just ask the patient, see here, when they will see here, this, the patient will apply this single and then in yellow one they will apply double. So they will apply the V pattern.
नहीं अभी तो ये रोटेट क्या है ना
इसमें इजीली क्या रहता है, इसमें पाउडर
पेशेंट को क्लोज कर पा रहा है, ठीक है। ये तभी करेंगे जब हमारा कोई आँख सप्रेस ना हो, जैसे सर ने बोला था। ये इसमें हम फ्यूजन को स्टूडेंट करते हैं, ठीक है। तो जब सप्रेस करेगा तो हमारा फ्यूजन फाइनल प्रोसेस रहता है, तो हमारा फ्यूजन ही होगा। तो ये जो आपको
not correlate what he asking because they are very familiar with this all instrument because they have been in a shroff charity eyes for short period of time, right? Okay. Okay. So this is what? Correct. We can use. Correct. We can use. So this is also, for example, patient have exophoria. Let's take an intermittent exotropia, right? So patient is what? If the patient, this is used for the distance, and that one used for near, correct. So another a very familiar card is, everybody know this about this. This is what? CAT card. CAT card is, as we know that what is CAT card, right? I don't need to explain this, right? I think I'll explain this a barrel. Let's take example of barrel. So when to use it, barrel? So everybody know how to use it? Just hold at the nose. So what? Then what we need to do? Just combine it, right? We need to.
तो हम इसमें क्या चेक करेंगे, हमें चेक करना है एसएमपी कितना एंगल ऑफ रेडिएशन, एसएमपी लिखते हैं, फिर फ्यूजन एंगल क्या है, कितने फ्यूज करते हैं. तो मैनिफेस्ट में ऐसा होता है कि आपका एसएमपी और फ्यूजन आएगा, मतलब 40% आपका एक्सोट्रोपी पर हो सकता है, पेशेंट 20% पे फ्यूज कर लेता है, और 20 जो है फिर वो कंट्रोल वाला स्क्विंट हो सकता है. तो ऐसा पॉसिबल होता है, समटाइम्स सेम पे ही फ्यूज करते हैं. सो वी विल हैव टू सी, बट जितना आ रहा है और जितना वो इंटरमीडिएट में होगा, ऐसा मैनिफेस्ट में नहीं होगा. मैनिफेस्ट में जितना आ रहा है उतने में फ्यूज करेगा, तो विच मीन्स
slowly. एक step हो गया, क्या हो गया? Try to maintain all three in the same line. जब वो तीनों एक लाइन में रहेगा, फिर हल्का सा और फिर आगे फिर से लाइन करो, फिर से मूव करो. Convex exercise plus anticipation भी हो रहा है साथ में. Audience with anticipation.